On behalf of Mental Health Foundations, I'd like to welcome everybody for attending this webinar. The live introductions for the webinar today were not recorded, so I'm going to provide an introduction, brief introduction to myself, but also to our presenters and the content of what they'll be sharing with us through this EFFT clinician consultation training today. My name is Sheila Paluzzi. I am a co-director of Mental Health Foundations, and I'm also a supervisor and trainer in the emotion-focused family therapy model. I would like to just take a moment to thank any of those participants out there who did donate as part of participation to this webinar, and want to just extend gratitude. Those donations help us just to maintain the technology and any overhead costs of being able to produce and deliver these webinars and other videos that we create that we try to make available to the public. So with regards to the webinar today, we have Dr. Sherry Maiman and Dr. Catherine Henderson, and they're going to be presenting C-Care model, which is founded on EFFT and EFT and used with concurrent disorders, with eating disorder and substance abuse. And both Sherry and Catherine are practicing out of Ottawa, Ontario, and they are the co-founders and co-directors of Anchor Psychology. And more specifically with context EFFT, they are also both registered with the International Institute for Emotion-Focused Family Therapy and are supervisors and trainers in that domain. Both Catherine and Sherry also assisted with co-authoring, along with our very own Adele LaFrance, with the APA manual for emotion-focused family therapy. So we're very, very excited to have them here to present and share some of their wisdom and their knowledge and their skill in terms of how they've adapted EFFT to fit with concurrent disorders. So I will lead you into the presentation now and hope that you enjoy. If you do have any questions, you can feel free to connect with us at Mental Health Foundations or with Catherine or Sherry directly, as they provided their contact information at the end of their webinar. Hope you enjoy and have a wonderful day.
And this is really a little bit of a taster. When we train in this model, it's about a 4-day training. So we're just going to highlight some of the main components and talk a little bit about why the need for a model for concurrent ED and SUD is so important. I wanted to tell you just a little bit about how this model came to be. So Catherine and I both have a really strong background in the treatment of eating disorders. We actually met at the Children's Hospital of Eastern Ontario. Catherine was the clinical director and the lead of research in the eating disorders program there, and I was a staff psychologist. And we spent a considerable amount of time in that domain before we came to start Anchor Psychological Services, which is our private practice. And at that time, we were approached by one of our former colleagues, Nadine McLean, who had herself worked on the eating disorders unit at CHEO and was now working at Rideauwood Family Services, which is a service for addictions and mental health here in Ottawa. And Nadine had very astutely, with her eating disorder background, really made note of how much concurrent eating disorders and substance use was present in the clientele at Rideauwood. And she took it upon her to ask us to come and address this with a treatment model. And that's how C-Care was really born. But of course, prior to that, we had both had lots of experience in some of the challenges when individuals have concurrent ED and SUD. And we're going to talk a little bit about why that's such a difficult combination in the current treatment landscape. So our brief outline for today is we're going to talk about why concurrent disorders are important and why we need a treatment model for them. We're going to talk about some common shared risk factors and functional roles of both eating disorders and substance use disorders. And I'm going to slip into the ED, SUD just for time's sake. We're going to talk about a central shared risk factor between the two of them. And then we're going to outline different components of C-Care. C is for concurrent, and the care part stands for caregivers across the lifespan recovery coaching, and emotion processing. And those of you familiar with EFFT, which I think is a lot of you out there, you're pretty familiar with what some of those things are already about. We're not going to get much to integrating concurrent care into your practice today, but happy to answer questions about ways to start. So why concurrent disorders? Well, in addition to some of our personal experiences seeing the co-occurrence of eating disorders and substance use difficulties, the research really shows us that there's extremely high prevalence rates out there. The estimates are that between 17 to 50% of eating disorder patients meet criteria for a substance use disorder. And about 1/3 of substance use disorder clients report eating pathology. So those are pretty high numbers, which tells us that there really is a fair number of people dealing with both of these things at the same time. And it's also important to note that when we're thinking about substances, many of the substances used as symptomatology within eating disorders, like laxatives, steroids, appetite suppressants, are included in these kinds of substances because they're used problematically and abused within eating disorder symptoms. So the numbers are high, but also the risk level is really high. When we look at this population and we look at some of the physiological risks, the medical risks of eating disorders and of substance use disorders, these obviously multiply when we have both of those present in one person. In addition, both of these disorders are associated with higher rates of suicidality and mortality. So this is something that's happening fairly frequently. There's a really high risk level, and so it's really important for it to be addressed. But I think one of the key pieces for why we need a concurrent model is really about the gaps that are in resources for this population. So currently what the landscape looks like is that there's a lack of professionals with specialized training in both eating disorders and substance use disorders. Why is that? Well, first of all, anyone who works within eating disorders knows we're in the minority. Training is hard to get. Many people are reluctant to take on eating disorder treatment, and this is actually true with substance use disorders as well. And there may be some specific blocks that people have about taking on these populations. So the opportunities are slim, but people hesitate to take this on because of the high-risk nature of these individuals, some of the misconceptions that people have around these populations. So there's just not so many of us out there. That's number one. What we have even less of is integrated programs. So there are very few, if any, programs that will concurrently treat substance use and eating disorders. And this really leads to a number of problems that we'll talk about in a moment. Typically, there's exclusionary criteria within eating disorder programs around substance use and vice versa. So it's basically, if you're coming into this program, you can't have this problem, and that works both ways. There are very few evidence-based outcomes out there, and there's really a lack of treatment protocols for a concurrent population. So what does this do? What's the effect of this? Anyone who's worked in one of these areas and has had experience with a patient who struggles with ED and SUD concurrently probably has a story or two about a patient where they struggled to find resources and support. So certainly my experiences working within eating disorders and knowing that my clients had substance use as well, I've experienced them being kicked out of eating disorder treatment when substance use was occurring, or when people found out about substance use, or being excluded or refused eating disorder treatment, and also then not being able to get their substance use treated because they were told they needed to manage their eating disorder first. So what this does is it leads to people bouncing back and forth if they're getting treatment at all, or actually being refused from treatment. Take care of one before you come and treat this other problem. This is problematic for a number of reasons. First of all, the idea that we can just sort of separate out and compartmentalize the symptoms and compartmentalize these disorders doesn't really make sense from a clinical perspective. But also, what happens is we get sequential treatment. We have separate specialists, one of which is ignoring one illness while they're treating one, and the same thing happens when the other is treating the second illness, right? Ultimately, it leads to a lack of continuity of care, which we know is something really important for good care provision. And what we get is multiple providers in multiple locations with different theoretical orientations, different staff training, and different treatment protocols. There's nothing integrative, there's nothing holistic for people who are struggling with concurrent ED SUD. And it's incredibly frustrating and leads people to feeling often hopeless and like there's nothing out there for them. I think that also leads to hopelessness on the part of clinicians because we often don't know where to send people and how to help them in that way. What are some of the treatment challenges with this population? Some of the treatment challenges that are there sort of exist within each of these issues, but then they become a little bit compounded when we see them concurrently. Both individuals who struggle with substance use and eating disorders tend to deny the illness. Denial is a key component, and we know that these disorders tend to be ego-syntonic rather than ego-dystonic. People want to hold on to them because they are soothing, because they are powerful. So denial is sort of one treatment challenge. There's often a reluctance to treatment, as I mentioned, because of the ego-syntonic nature of these challenges. And there tends to be a pretty complex presentation because even though we're talking about the concurrence of ED and SUD, there are usually other comorbidities that go along with both of these disorders, like anxiety, depression, and trauma. These illnesses tend to be quite chronic and with very high relapse rates. And all of this comes along with high physical and psychological risk. So these are not easy problems to treat, but for people who take on this area and who like a challenge, there's considerable benefit to learning how to manage these concurrent issues. So what are some of the shared risk factors and the functional roles of eating disorders and substance use disorders? So, both ED and SUD has a genetic component to it. We know that they both run in families. There's genetic heritability that's confirmed by twin studies. There are temperament and personality factors common to both of them. So one would be the super feeler temperament, which those of you who are familiar with EFFT know lots about. And we'll talk a little bit about that in a couple of minutes. Impulsivity is also common among individuals with eating disorders and substance use, especially those who tend to have more of a binge purge presentation to their eating disorder. Less so in the restrictive eating disorders, but sometimes there is that present as well. Early life trauma is another common risk factor, and there is a higher rate of abuse in the concurrent population than in the regular population. Certainly, the shared risk factors are stressors, and the stressors interact with the vulnerabilities that I've just mentioned. That's common to all mental health difficulties. But then there's also this larger kind of community and cultural factor that I think is really important. When it comes to eating disorders, individuals who are struggling are constantly met with messages in the larger culture around food, around weight, around shape, around the ideal sort of view of what is beautiful and what is acceptable. When Catherine and I really moved into the substance use disorders treatment, we became much more aware of how true this is for substance use as well. There's so many messages about using alcohol, about using drugs and substances as ways of coping, often in humorous ways, that this is a challenge for people who are getting these kinds of messages. So all of those memes that we tend to see on Facebook and in social media about, moms needing their wine to cope with parenting, or what time is it, it's wine o'clock. These are kind of similar to all of the messages around food, weight, and shape for individuals with eating disorders. But what really struck us in terms of this shared risk factor among eating disorders and substance use disorders is the one that we talk about a lot within EFFT, and that's the relationship among the sensitive superfeeler temperament, emotional avoidance and dysregulation, and maladaptive coping. So we're going back to the core importance of emotional avoidance here. Some of you might have already seen a version of this diagram to really talk about how individuals can get to maladaptive coping, and I'm just going to walk through it. When an individual experiences a stressor, and stressors can differ in terms of their severity and their impact, partly just in terms of what the stressor is, but also in terms of how it can interact with temperament. When individuals have a stressor that they experience in their life, they tend to get a response from the environment. And because we live in a culture that is really struggling to know what to do with feelings, often responses to an individual having a stressful event or even a traumatic event, the responses can be misattuned. That means that individuals in that person's world aren't validating their experience, they're not noting the emotional impact of those experiences. And when that happens over time, what can occur in a person is a real confusion and a lack of confidence about their emotions. When the opposite happens, when attunement happens, when someone really validates, okay, this experience has been stressful for you, it's been difficult, you feel scared or you feel sad, what happens for the individual is that over time they start to connect what's happening inside their body, the physiological symptoms of emotions, with the label of emotions, and they understand that their emotions make sense in response to what they're experiencing. And that leads to an efficacy around emotion and a confidence around emotion. When that isn't there, people start to engage in some avoidance of their emotion because they don't have that sense of self-efficacy. And when people start to avoid emotions, either by ignoring, by suppressing, by distracting from them, there becomes sort of a fight internally with their emotions. We all know that emotions are adaptive, they're healthy, we're meant to pay attention to the signals that emotions give us. And when we don't do that, when we thwart our emotions, then the needs of our emotions are not met. And those avoided emotions tend to fester and fight. They don't just sort of sit quietly and go away. And what individuals start to discover is they need stronger, bigger, and more powerful kinds of behaviors in order to really squash those emotions. And really, those of you who are familiar with individuals who struggle with eating disorders and substance use disorders know that they are pretty powerful strategies for squashing, suppressing, and avoiding emotion. Now, you'll note that in our diagram, we've talked about this sort of as what happens when people experience stress. If you add in the superfeeler temperament, it's important to note that this is probably even a more sort of intense experience, that the tendency for misattunement is greater. Superfeelers, which are the 10 to 20% of us in the population who feel things more intensely, who pick up on others' emotions, who have bigger and stronger feelings. For them, smaller stressors tend to have a bigger impact, and the risk of misattunement is probably greater because they're not experiencing things the way 80% of the population are. So individuals around them with very good intentions who are trying to help them as best they can may inadvertently give them messages of misattunement, invalidate their experiences, and that can really lead to this pathway. So I think this can occur with or without the superfeeler temperament, but certainly the superfeeler temperament really increases the risk. And our clinical experience would say that those with concurrent ED-SUD certainly fall into that superfeeler category. So what is emotional avoidance? It can look like a lot of things, and sometimes people discount the idea that one can look quite emotional while still being emotionally avoidant. So emotional avoidance can include difficulty identifying emotion, so even knowing what emotions are, difficulty expressing and labeling emotion, inability to tolerate the emotion. So that's really the idea of sitting with emotion and not needing to do something to escape that feeling and to escape that experience. The suppression or squashing of emotion all fall into the category of emotional avoidance. But emotional avoidance can also look like emotion. So individuals can mask one emotion with another. If one emotion is maybe a little bit easier for them to feel or to express, they can bring that one forward, even though that's not the primary emotion. So an example of that would be to constantly be angry and to express anger and to be in a very angry place when there's deep sadness and hurt underneath, or actually vice versa. And dysregulated emotion, so lots of emotion, emotion kind of all over the place, can be another form of emotional avoidance that we see, which is a bit tricky because it doesn't look exactly like emotional avoidance. So when emotions are followed through, meaning that a person experiences an emotion and they are well able to say, this is the emotion that I'm feeling, this is the need that goes along with my emotion, and I can meet that need in these ways. If they're able to do that, then emotional challenges become less scary and they're more manageable. And individuals don't need unhealthy coping strategies to deal with their feelings. But when emotions aren't followed through, so when emotions aren't expressed, if the needs are thwarted, then emotions over time become feared and avoided, and they feel overwhelming. And this fear of emotion, emotional intolerance or avoidance, is the phenomenon at the root of most addictions and eating disorders. So really, when we think about the symptoms of substance use and eating disorders, they are ways of tolerating, managing feelings. In this way, we can look at how SUD and ED have adaptive functions. Now, in the moment for individuals, these symptoms, the use of substances, restriction, binging, purging, overexercise, all of the symptoms associated with concurrent ED SUD, they serve a function, which is to escape, avoid, and numb, to punish the negative self, because these individuals tend to have very strong critics within them, and to medicate and manage mood disorders and anxiety. It's also important to know that substance use and eating disorders can be mutually reinforcing and mutually triggering. So in this way, they have a relationship with each other. Many individuals who start off with substance use can move into eating disorders because substance use is often associated with appetite dysregulation and weight loss. So cocaine, for example, is an appetite suppressant. Many of the other stimulants are appetite suppressants. If an individual has sort of entered into substance use and then experiences some of this appetite dysregulation and weight loss, they might find themselves tipping over and being triggered into an eating disorder, where suddenly there becomes a preoccupation with weight and shape. The eating disorder kind of blows up, and it was triggered initially by some of the side effects of substance use. And similarly, individuals who are engaging in eating disorder behaviors often want to quiet and calm the emotions that they have. They want to engage in some substance use that will help them with some of their symptoms. Restriction and binge symptoms can then trigger substance use. Additionally, individuals with eating disorders might use substances for the purpose of appetite suppression, or even the opposite, to kind of give them permission to eat. So for example, if they're engaging in cannabis use, to occasionally allow themselves to feel the feeling of hunger and need if restriction is a big part of their lives. And some individuals manage physical discomfort caused by eating disorder symptoms through the use of substances. So these things kind of easily hang out together. So what is concurrent care? And concurrent care is a comprehensive treatment model. That means it's pretty complex and it has a lot of components to it because these issues are complex. The C in C care is for concurrent disorders, and the care, as I mentioned, stands for caregivers across the lifespan, recovery coaching skills, and emotional processing. And we like to show this picture to sort of understand how all of these components of C care fit together. You'll note that the biggest gear is emotion. And so because the theory is that emotional avoidance is at the core of substance use and eating disorders, and therefore relearning emotional processing is the way out of concurrent ED and SUD, emotion is our biggest cog. However, we can't just focus on interrupting emotional avoidance as the only way through, the only way to treating these illnesses. There's a number of problematic symptoms and behaviors that begin and maintain themselves over time that need to be addressed through recovery skills. And in the recovery skills cog, we're focusing on interrupting the symptoms that go along with these with these disorders. The other cog is caregivers across the lifespan. So C-Care is absolutely a lifespan approach, much like EFFT, and we look at involving caregivers throughout the lifespan and recruiting caregivers to assist us in the processing of emotion and in the interrupting of symptoms. What we've done with C-Care is we've really pulled from the evidence-based treatments out there, and we've layered them into each part, each component of the model. So to address emotion and to increase emotional processing, we focused on skills from EFFT, Emotion-Focused Family Therapy, and also individual EFT, Emotion-Focused Therapy, the Greenberg model. In our recovery skills component gear, we're really using a lot of the skills learned in family-based therapy for eating disorders, as well as dialectical behavioral therapy, motivational interviewing, and cognitive behavioral therapy. And we draw from the new Maudsley approach and EFFT in our cog around caregivers and using caregivers across the lifespan. Okay, so I'm going to hand it over to Catherine. She's going to pop in and talk about the detailed components of the model, and I'll be back for our question and answer period.
Oops. Hi, everybody. Thanks for joining us today on a Friday over what might be your lunch hour, or maybe it's early morning or late in the day. So as Sherry said, the C stands for caregivers, and as most of you work in EFFT, you'll already be converts into why we included caregivers in this model. And so really the guiding principle for us, because we are also people grounded in EFFT, is the recovery from mental illness is really made easier with the involvement of supportive others. And you know what? Caregivers are highly invested in the well-being of their loved ones. Caregivers, whether they're partners, whether they're parents, whether they're aunts or uncles, or maybe they're even group home staff, usually are the people in the world who know the individual the best, who probably love them the most, and are in a unique position to help. And so they are this incredible resource full of lots of love that really we need to get better at including in the treatment of particularly complex challenges such as a concurrent eating disorder and substance use disorder. We want to help caregivers become empowered in their role, helping. We want to encourage their involvement wherever possible. And part of C-Care, just like an EFFT, is really to encourage clinicians and therapists' idea of when it's possible. And working with the addictions agency that we've been working with for the last, to be 4 years now, that notion of when it's possible is a really important one, because in Sherry and I's mind, when it's possible is just about all of the time. There's almost always somebody in somebody's world who could be a helpful, supportive person. You know what? And caregivers are people, and they can be taught a set of skills no matter what level they're coming in at, no matter what their knowledge of mental illness is, of addiction. We can always recruit them as partners and increase their skill set and be partners in the treatment team. And we are looking that caregivers can replicate the support, the containment, and safety that nurses and counselors do when you go to an intensive program. So substance use disorders are known for having intensive residential programs, as are eating disorder programs. And what we're saying to caregivers is we can start replicating some of that in the outpatient world, so that if your loved one needs to go into an intensive care, when they come back out, you can help ease that transition. Or perhaps we can prevent them from having to go into an intensive treatment program by providing this level of care and support and training caregivers so that they have those skills. And so A in care is across the lifespan. And, you know, this is so important. Eating disorders and substance use disorders, they don't magically change in adolescence and adulthood. Nothing, I always say to the people I work with, look, nothing magical happens when you're 17 years old, 11 months, and 30 days. And because nothing magical happens on your 18th birthday. That eating disorder and addiction that you had before is still there. Your needs are very similar. And so really looking at this model applies whether you're a child, an adolescent, a young adult, or an old adult. And, challenging ourselves to stop thinking that we need completely different treatment models after a certain age. Eating disorders and substance use disorders, well, you know what? They interrupt normal development. And so particularly if it started during childhood or adolescence, a lot of the normal development that has needed to occur has been stalled, has been interrupted. And so those individuals sometimes are stuck in a different part of their development and are more reliant on caregivers than they would have been had they not struggled with a concurrent ED SUD. And you know what? People don't just need their caregivers when they're young. We need them whenever we are in pain and suffering. And if you have an ED, SUD, you're absolutely in pain and suffering. And so you need those people who love you the most to be most available to you, to help support you fight your way through these very difficult illnesses. And the other piece, as Sherry talked about, we have a real challenge in ED-SUD in terms of competing models, competing language. We really don't need the models to change when you turn 18. So having a lifespan approach provides consistency, which helps individuals, which helps clinicians, which helps families, and really is going to allow us to have better outcomes. Then the R is for recovery coaching. And we look at recovery coaching at both the individual and caregiver level. So when we developed C-Care, we really were looking at what are you going to be doing with an individual when you're using C-Care? What are you going to be doing with the caregivers when you're doing C-Care? And who else do we need involved in the model? So recovery coaching for the individual is teaching them how to interrupt their symptoms of the eating disorder and the substance use disorder, and really using a harm reduction approach. So we're always looking at taking wherever they're sitting and reducing those. And what's so important is that we don't just look at one at a time, right? So what happens when we send somebody to an eating disorder program, well, so let's say they started here, well, their eating disorder symptoms go down, but their substance use symptoms go up because nobody's asking about them, or vice versa. We send them into the substance use disorder program, the substance use goes down, the eating disorders escalate. And so what we're looking at when you're in C-Care with the individual saying, okay, we want all of those symptoms on the table, and we're going to work at reducing both of them at the same time. And so in the same way that we're going to say, can we take it down from a more harmful drug to a less harmful drug, or can we reduce the number of times you're using from 10 times a day to 8 times a day? And at the same time, I need you to hold the eating disorder symptoms steady and not let them increase. Or I'm also going to delay the binge for half an hour at the same time as we're delaying substance use. And so we're looking at those at the same time with the individual. And so with recovery coaching, because of course we're EFFTers, we're also going to include the caregivers in this and teach them the skills that we are teaching the individuals and empowering them to support their loved ones to interrupt these symptoms. So whether we're teaching caregivers about meal support, about different replacement behaviors we can help put in place of instead of restricting, binging, or purging, all the distraction, because if we can have some distraction to help them delay either of those symptoms, eventually we can delay for long enough that they don't have either symptom. And again, we're looking to create a safe environment. So we're going to look at both, though, and merge them together. So as Sherry and I were saying, we came from a strong eating disorder background and have been developing our knowledge around addictions and really looking at how do you create a safe environment? You have to take out all the dieting messages, and then you have to take out all the jokes and talk about substances and substance use, and you have to probably make your home a home that's free of substances, along with a home that's free of dieting, and where we're providing balanced nutrition and where the message is all foods fit, And variety is key. And so we're looking at that. We're looking at creating a safe environment for someone to start to challenge themselves to no longer use the substance and to be able to fight their eating disorder. And so that's what we mean about creating a safe environment. It's a place where substances aren't, where you're not going to be triggered by people drinking, you're not going to be triggered by people restricting or binging themselves on different foods. And so we're really mobilizing the power and the resources of those supportive others to create change and recovery, no matter who they are. So when we look at the R of recovery coaching, we're doing it at the individual level and the caregiver level. And what we're going to do is we're going to integrate the tailored skills from evidence-based care. CBT and DBT have great evidence-based care outcomes in the research, but we really feel that on their own, they're rarely sufficient when you're looking at somebody who's struggling with concurrent ED, SUD. So we're going to provide both the individuals and their caregivers with the toolkits from CBT and DBT to help them interrupt symptoms, to develop more positive coping strategies, and to engage in more effective emotional processing. And so some of these tools are tools like relaxation, teaching relaxation strategies, teaching distress tolerance, teaching mindfulness, looking at functional analysis, what's the function of some of my symptoms, and teaching urge surfing, because we can urge surf our way through an urge to binge, and we can urge surf our way through an urge to take more of my prescription medication than is prescribed. And so these are the things, but I can teach both the caregiver so they can support their loved one, and I can teach the loved one these skills so that we have this powerful strengthening so that an individual is not left on their own. There's someone who can step in and say, hey, how about we try this skill that we learned yesterday? So finally, E is the emotion processing. And if you might recall when we did the cogs, it's like our biggest cog. It is really the place where Sherry and I feel that, this is the main shared risk factor, and we want to have a real emphasis on the emotion processing. We can't ignore the symptoms. We need to give the skills. We need to build the skills. But the individual and caregiver are going to work really hard on the emotion processing aspect. So in this slide, I want you to look at it. So we call this emotion processing, the goals that we have in C-Care and the tools. So under the word goals, on that side of the slide, those are our goals. And on the side that says tools, under that, those are the tools we're using. So when we developed C-Care, we were thinking about emotion processing and what is it that we're trying to achieve through emotion processing. And we're first initially looking to help individuals learn to access their own emotion, because if they have developed a style of avoiding emotion, they have likely lost a lot of their innate ability to access their biological emotions that are so driven and so important in our world. And so our first step is accessing the emotion. So our goal there is that we're going to increase their awareness and their ability to express emotion. And how are we going to do that? We do that by teaching the skills of emotion coaching and chair work. And then our second broad categories, we're looking at modulating and understanding emotion. That's a big piece of being able to successfully process emotion. And so our goal is that we're able to regulate and reflect on our emotions. And how do we do that in the C-Care model as clinicians? Again, we're working with emotion coaching, both with the individual and with their caregivers, and we're doing chair work, again, with both sides. And finally, we are hoping to transform emotion. And so with the clients, we're looking to transform emotion with emotion and or transform it through a corrective experience with ourselves as clinicians, with their caregivers, and the people involved in their care. And how do we do that? We have chair work, we engage in relationship repair, we do block work. And so this is sort of our overriding look at what is it we mean when we talk about emotion processing. And if we break that down, what's that going to look like through our sessions? And in a large treatment program, whether you're a large treatment program like the program where we've provided the training, or you're an individual in private practice like Sherry and I, working with clients. So there's different components of the emotion processing. The first component is emotion coaching. And so much of this will be very familiar to those of you who are experts in EFFT already. So in emotion coaching, as many of you know, what we love about emotion coaching is that it's really a system of enhancing attunement and validating emotions and encouraging the development of emotional self-efficacy over time, right? So when we emotion coach the individuals in our office, when we emotion coach caregivers about how hard it is to have a loved one who's struggling with SUD ED, and we teach caregivers how to emotion coach their loved one, we are creating this landscape that's a landscape where we have attunement to emotion, where suddenly emotions are having validation as the primary priority that is occurring, which leads to the development of emotional self-efficacy. Emotion coaching is, of course, based on Gottman's emotion coaching, which is where the EFFT emotion coaching is based on. And the beautiful piece of emotion coaching is that it occurs throughout the system. As I said, the clinicians emotion coach the clients and the caregiver, and then we train the caregiver and they emotion coach their loved ones. So we have this full circle in creating as much opportunity for the ability to start to learn to access emotions, to create meaning for them, and eventually to be able to express them ourselves. Okay, and of course, when we train caregivers on emotion coaching, we're going to use role play, we're going to do practice, we're going to sculpt a voice and do body language. So, this piece is so important at both the individual and the caregiver level in the model. Another component of emotion processing, and one of the tools we use, is chair work to facilitate emotion processing at all those different levels that we're looking at. And one of the things we love about chair work is that it helps clients truly experience emotion. We're not just talking about emotion, we're going to experience emotion in the office. It's really the living and feeling the actual emotion in the session. And because we have access to the actual emotion, we have an opportunity to transform it. And with chair work, we deepen the work of becoming aware of the emotion, we intensify the actual experience, and then following that, we can transform the emotion. So particularly individuals who are feeling and only able to express anger and aren't able to find their sadness, this is one of the important ways where we can transform that experience for them. Chair work is very powerful in helping individuals be able to access emotion that when they're talking to you, they really just find it so difficult to feel. The number of clients that I work with ED, SUD, who can feel emotion in the chair, but really struggle to feel it when talking with me. The chair work is just so powerful that way. So the individual chair work with the client becomes extremely important. The main tasks we do in the individual chair work are having the eating disorder and substance use disorder in a chair. So that is the other in the chair, and you do the chair work that way. Another big piece, of course, is the self-critical dialogue. The self-critic is strong in eating disorders. Those of you who work in eating disorders will know that, the eating disorder illness itself is so critical and so harsh, but so is the addiction part and the substance use. And there's so much shame involved in struggling with an addiction that the critic is so loud and constantly telling them what a failure they are, how worthless they are, and how undeserving they are. So it becomes super important, this chair work, to heal the self-critic and to change the self-critic. And then, of course, there's self-interruption, right? The self-interruption is the don't feel, don't go there. And so these tend to be the three main chair works that we focus on. And unfortunately, we don't have enough time to really talk about it more than that. So if you're not familiar with chair work, really just know that it's a technique and a skill that allows you to deepen emotion in a way that's very different than really just talking about what's happening. People get to experience what's happening. It's very experiential. So another component of emotion processing is looking at relationship repair. All of us have many opportunities where relationship repair would be helpful to us and powerful to us. And when we've been struggling with an ED and SUD, there are often old wounds that, you know, it would be helpful if we could heal them, because they might have led to a reliance on some of the maladaptive strategies that the SUD and ED are providing to prevent pain, to suppress whatever was difficult in that moment. So with individuals, we do work on relationship repair, and we use the EFFT model of relationship repair, of teaching caregivers about healing the old wounds, about how we can do that through an apology and the unique impacts of the break in the relationship. And so in C-Care, we look at if we have an individual working on healing old wounds and working with the caregiver on healing old wounds. So at multiple levels doing this work. So how do we do that with the individual? One of the strategies can be unfinished business chair work, which is in EFT is a recognized piece of work that is done where you have a loved one and there's a piece of work that's unfinished, and we work that through with that other in the chair, imagined other in the chair. The other piece of C-Care that we've built in is to do the apology chair work, where an individual can write the apology from the person they need it from, usually often a parent, and deliver it to themselves through the chair work and feel the power of receiving the apology they needed and that their loved one isn't able to give them or hasn't been able to give them, and really allowing them as an individual to receive that apology and to have the healing. So there's sort of two different ways we do that. And having the caregivers in our office to actually have a live apology provided by the caregiver and the healing aspects of that. So it's important for those of you who aren't as familiar with EFFT, and we always say this, it's about holding the dialectic, that when we talk about an apology, that families are not to blame and they do not cause mental illness. And so what we are doing, though, is we're offering the gift of the apology, that we have an opportunity to heal old wounds, that there may be burdens that can be shared, and the loved one's going to feel less broken, and the caregivers are going to have their self-blame lifted. So we're always, when we're working with caregivers, it's so important to tell them, I know you did the absolute best you could, and to really genuinely, with all of our hearts, know that caregivers are so important in their worlds, and really that we are not blaming them. We hold them not to blame at all, but really that we want that balance of, we have an opportunity to heal, but of course you weren't to blame. And so we actually find that most caregivers come to this and feel empowered by this. And it's only clinicians who struggle with this concept and worry that it's going to be blaming to families and to the caregivers that we are working with. The last component of emotion processing is the block work. And so in the block work, we from the foundation of EFFT, it is expected and considered normal that all levels of the system are going to experience blocks will interfere with therapy throughout treatment, and that the individual is going to experience blocks, the caregiver is going to experience blocks, and the clinician is going to experience blocks. And the foundation of this is, of course, is that none of the blocks are due to a lack of motivation. Blocks are simply fueled by emotions, and those emotions need to be processed. There's some other emotion that's driving me to do something different than that which my treatment would suggest we should be going in. And so these are powerful blocks, and there's usually wisdom in those blocks. So when we're looking at the individual blocks, these are the ways in C-Care that we work with an individual. Part of it is simply the therapeutic relationship, is sometimes the corrective emotional experience of the therapeutic relationship starts to shift the block and starts to shift the challenge perhaps of trust and fear of being vulnerable can shift. Through emotion coaching, we talk about the fear and the things getting in the way. Through emotion coaching, we can help alleviate some of the things that are preventing an individual from progressing and moving forward, perhaps from preventing them from trying out new skills. And then, of course, we have the power of the chair work. In chair work, we can put that interrupting part in the chair and say, don't do it. Tell her not to. Don't listen to Dr. Henderson. Don't do what she says because. And so the chair work is a powerful way to address the blocks. And of course, we can do relationship repair with the caregiver. And with that is working through that apology, doing some of that. And when all of us around them work on our blocks, we facilitate an individual from being able to work through their blocks. The caregiver blocks, we do it by educating caregivers about their blocks. We normalize blocks as a standard part of the journey to recovery. And then, of course, we have the opportunity to do the powerful chair work that we use in EFFT, targeting a caregiver's unique blocks, using the scripts and working them through. And what we usually find is caregivers have some real fears that are going to get in the way. I'm afraid if I do this, then they'll take more drugs and they'll overdose. I'm afraid if I do this, then they'll stop eating for good and they'll die. So and you know what? The risk is high of both of those. And so really being able to honor those fears, to work with caregivers through those fears. We live currently in the days of high opioid use, with opioids that cause fairly instant death. And so it is a very scary time if your loved one is struggling with an ED, SUD. It has always been scary, but it's even more scary these days. And so it's really challenging for caregivers. There can be many blocks with much wisdom to them that we need to help them work through. And then as clinicians, we all have blocks. And one of the things, of course, in C-Care is we're going to educate clinicians about that. We're going to talk about these are some of the ones you're likely to experience. It's totally normal part. And you know what's helpful is if we work through them and we talk about them and we keep talking about them and having peer supervision. Peer supervision with the facilitator is probably sort of the Cadillac model, but of course most people don't have access to that. Here at Anchor, we work together collaboratively with all the psychologists, doing peer supervision, challenging ourselves on our blocks, doing chair work around our blocks. And we've created a culture of self-reflection that really helps us come in and say, I'm stuck. I can feel this piece that's getting in the way. And, you know, the chair work is also very powerful for clinicians as well. It's really helpful to have this as a standard part of peer supervision, because when you're working with ED, SUDs that are concurrent, it's challenging and we will experience many blocks and we can feel helpless and we can feel hopeless. And, you know, this is part of the emotion processing. So one of the foundations, of course, around if we can achieve sort of confidence in emotion processing, if we can have emotions followed from beginning to end, then you know what, problematic behaviors are really no longer required when our emotions are fully processed. So at the end of the day, in the C-Care model, what we're looking for is an adaptive processing of emotion. So we may start with a painful experience, and it may be a painful experience and I'm a super feeler. So it's like take the painful experience and multiply it by 1,000,000, right? And so whether the painful experience is a little bit or extremely painful, I have the painful experience, and through my work in C-Care, oh, look, I have an awareness of my emotion. I can notice the bodily sensations of that. I can put a label to that. I'm going to express that to myself. I'm going to say to myself, wow, that's really scary. I'm really sad. Or I felt my friend really rejected and let me down there, and I'm sad and I'm scared and I'm angry. I'm going to express that to myself or to someone else. And then I'll have learned some regulation skills. I'm learned to regulate the emotions. I'm going to pull in my DBT skills. I'm going to pull in some of my CBT. I'm going to talk myself through it. There's lots of people who love me and care about me. I'm going to pull in my art project. I'm going to do some deep breathing. And then at the end, I'm going to be able to transform my emotion. And then I no longer have a need for SUD and ED. So there is some limited research, of course, that the components of the model have been researched. EFT is well researched. EFFT has a really strong foundation of research that's growing. CBT is an extensive one, as is DBT. We are evaluating this in an agency over the last 3 years. We have some preliminary findings that are really strong. And this is us, and you can hear about us here. And we're going to take questions and comments now. So we'll let Sheila come back and manage that for us. Hi, Sheila.
Hi, thank you both so much. That was absolutely fantastic. And there's been a lot of interest from a lot of you participants with regards to being able to access the materials and all of that. So what I probably should have said at the beginning is just to let everybody know that this webinar, you know, Catherine and Sherry were fantastic and allowed us to record it. So through Mental Health Foundation's website, you'll be able to access this webinar as a video in the near future. So I would say probably within a week. So there's not a slide, there's no handouts that you were required, but you can access the video if needed. And, you know, one of the things based on all of the interest throughout this webinar, do either of you have any upcoming trainings? Because I know this is 1 hour and what you have to offer is so rich. You know, are there upcoming trainings that maybe you can let the participants know about?
We do not have upcoming CCAR trainings yet.
Okay.
Typically, what we haven't sort of put them on ourselves. It's been places where they've had a particular interest in SUD and ED that has invited us in those areas. Just because the numbers can be pretty limited in terms of who's out there, we haven't put them on ourselves. But if anyone is part of an agency where these issues are front of mind or what you treat, we are certainly available for the delivery of training, but we're not running anything in particular right now.
Wonderful. So participants could just use your contact information to get a hold of you if they were wanting it to bring to their agency or anything like that.
Yeah.
Wonderful.
And if people are interested in sort of one-to-one kind of supervision, same thing.
Yes, and I know I did say at the beginning of the webinar as well, but for those of you who maybe weren't logged on yet, both Catherine and Sherry are also trained and as trainers and supervisors in the EFFT model as well. And it sounds like you would obviously offer that through your CCARE model also.
Absolutely.
And then one of the, because I know a lot of our EFFT trained clinicians that not all of them have training in EFT. So one of the things that even as the presentation was going that I noticed was when talking about that individual chair work, even just to delineate that is the training that you get from EFT. Yes. That individual processing with the self-interruption and all of that, just so that if they were looking to get extra training or anything like that with the individual chair work, that's mainly through the EFT model.
Yeah, and I will say, you know, some of those tasks can be a little bit scary and intimidating if you've learned anything about EFT. They seem like really hard to learn and difficult. And while I certainly don't want to minimize all of the beautiful training that you get through formal EFT training, when we developed this model for the addictions agency that we were working for, we delivered it and included the training on the individual chair work without a full comprehensive EFT training for those clinicians. They were clinicians of various backgrounds, various levels of training, and with practice and scripts, which we focus on a lot as we do in EFFT, we were really able to get people past those fears of chair work and find that they could take it on and use it well. And so while we would always recommend EFT as a training because we found it very powerful for us clinically, within CCARE, people can do pieces and still find it pretty effective and useful.
Wonderful. I appreciate that because I know some people may be out there wondering, do I have to have formal EFT training in order to take the training in CCARE and learn those skills? But that's wonderful to know. Excellent. Well, I definitely want to thank both of you for taking your time out today to be able to offer like this phenomenal training consultation for all of the clinicians out there, and on behalf of Mental Health Foundations to thank you both for your time. It seems like a phenomenal model and so needed, that concurrent integrated approach, you know, and not kind of treating people in silos in terms of their symptoms or their diagnosis. So very much appreciate that. And I'm not sure if there are any closing words that either of you had for today.
Sure, thank you, Sheila and Mental Health Foundations. It's such a fabulous opportunity, and the webinars are a great way to bring clinicians together and share knowledge. And we just hope that if nothing else, some of you start thinking about this outside of a silo and a little bit more as a unified thing, that without all the skills we talked about, you can start thinking about it and addressing it as one sort of issue in your own practice. And not be scared to take some of our ideas and run with them.
Yeah, that's always the spirit of EFFT. Just try stuff.
Go out, don't do it, have fun.
Yeah, it just truly, truly is, and appreciate everything and all the wisdom that you brought and experience you brought. And for the participants, again, this will be made through a video uploaded later on if you're wanting to go back and review any of the information, or even to be able to get into contact with either of these wonderful psychologists.
Thank you, Sheila.
Thanks, Sheila.
Thank you both. And
Joining
thank
us.
you everybody for joining. And we'll sign off and wishing everybody a fantastic weekend wherever you are.
Bye.
Bye.
Bye.